afternoon, everybody, and welcome to the midterm endocon. I'm Dr. Anshu Srivastava from the Department of Pediatric Gastroenterology at SGPGI Lucknow. And at first, I would like to thank the organizers for giving me this opportunity to speak on a very relevant topic which is close to my heart of pediatric IBD in India. In the Western population, pediatric IBD accounts for about 15 to 25% of all IBD. And although we don't have any population-based study on children from India, but there is recent data which suggests that roughly around 7 to 8% of all IBD is diagnosed in the children. Keeping in with the trend of a global rise of pediatric IBD overall, which is more for Crohn's disease as compared to ulcerative colitis, even at our own hospital at SGPGI, we have seen that the number of cases per year has increased from 3 to roughly about 20 in the last 12 or 14 years. Similarly, the multicentric data which we have just collected on pediatric IBD from the country has also shown that there is an increase in the number of cases in the last decade. And keeping with that are the numerous publications which are coming in the last 5 to 10 years. Some of them are listed here, some of them are not there because of lack of time. As you see in this pie chart, that in the Indian data of 325 children with inflammatory bowel disease, boys were 55%, roughly two-thirds or 65% were Crohn's and 28% were ulcerative colitis. In the north, ulcerative colitis is more common than Crohn's, whereas in the south, it's Crohn's disease which is more common. And this is similar to the Western data, except for this fact that only 7 to 9% of our patients have a family history of IBD, in contrast to the West, where it is more common and seen in roughly about 20%. Indeterminate colitis, or what we call as IBDU, is a very important group because children have IBDU more often than the adults, as shown from the data from Kerala, 15% versus 2%. They mostly have pancolitis, and it is very essential that we evaluate the entire bowel with an upper GI study, a lower GI colonoscopy, and a small bowel evaluation for the correct diagnosis. And as you can see from this Indian data, that IBDU is seen in roughly about 1 in 4 patients in those who are less than 6 years of age. Whereas as the child becomes older, the chances of having IBDU go down. And it is important to have a correct diagnosis because if you falsely label them as ulcerative colitis and subject them to a surgery, they have a higher risk of pouchitis and pouch complication post-surgery. Pediatric IBD is not a uniform group, and once the child is diagnosed at less than 10 years of age, we call it as early onset IBD. If it is diagnosed at less than 6 years, it's very early onset, less than 2 years infantile, and in the first 28 days as neonatal IBD. And there are 3 studies which have been published in this year in 2020. The SGPGI experience, the multicentric data, which is showing all in red stars, which has been collected from the centers in the north, south, east, and west of the country, and the data from AIG Hyderabad. And as you can see, that 7.5 to 19% of our children have very early onset IBD, in comparison to the Western population where it is 6 to 15%. And the most common age of diagnosis is 10 to 17 years. The problem is that very often children who have isolated abdominal pain and have presenting to you with the OPD with just this as a symptom often have a maximum delay because no one suspects Crohn's disease. And it has been shown that from the AIG data that roughly more than 6 months of delay is seen in 40% of VO IBD and 80% of late onset or the older children who come to with IBD. In contrast, in the multicentric data, it was about 4 months delay for ulcerative colitis and 6 months for Crohn's disease. Why do we have to make an effort for an early diagnosis is because a recent study has shown that if a delay of diagnosis is more than 9 months, then these children have a 2.5 times higher risk of presenting to you with stricturing or internal fistula. And they also have a reduced height. So the earlier we diagnose, the better these children tend to perform. And for this, we have the IBD refer criteria, which again suggests that if there is a child with bloody diarrhea or diarrhea without blood for more than 1 month or recurrent perianal abscess or fistula, these children should be referred to a pediatric gastroenterologist. However, if you don't have these, but you have two or more criteria of group 2, which would a typical setting would be an abdominal pain with growth failure or with a higher ESR, you should suspect that there could be a possibility of underlying Crohn's disease, and these children should also be referred earlier to the gastroenterologist. In our experience, Crohn's disease, the most common form in the Indian children is ileocolonic, and roughly about 73% of these children have ileocolonic, whereas the upper GI involvement is seen anywhere from 6 to 18%. And as you can see, it is similar to the data from the EuroKids registry. When we look at the phenotype of the Crohn's disease, 80% of our patients have the inflammatory phenotype, around 10% have the stricturing, and around 10% have the penetrating. Whereas perianal disease is present in 10 to 20%, and nearly 20% of our children have growth failure. Again, similar to the Western data. In ulcerative colitis, most often we see pancolitis, which is seen in 60 to 70% of the children, and nearly a third of the children have had severe disease one time or the other after being diagnosed as UC. Amongst the extraintestinal manifestations, what we found that in our data which we collected from various centers, nearly a third of our IBD had an extraintestinal manifestation, and of which oral ulcers, arthralgia were the most common, more often seen in Crohn's disease as compared to ulcerative colitis, and so was erythema nodosum. While in the Western data, it has been very clearly shown that angstpon and erythema nodosum were more common in Crohn's, whereas primary sclerosing cholangitis was more often seen in ulcerative colitis. Now, going on to this very important group of very early onset IBD, which is when we diagnose it in less than 6 years of age. Why do we need to recognize this? Is because in roughly about 5 to 20% of these patients, they may be having a monogenic disorder or an immunodeficiency, which is presenting with an IBD-like presentation. And it is important to recognize them because they are prone for specific complications, as well as the treatment differs. And in some of these conditions, a bone marrow transplant might be curative. And on the screen, you can see that there is a long list, 50 of them, which have been described to present as very early onset IBD. Some of the important ones being the IL-10 deficiency, the X-linked inhibitor of apoptosis protein deficiency, Wiskott-Aldrich syndrome, IPEX syndrome, and various other syndromes, chronic granulomatous disease, which have been diagnosed and they present like a VO IBD. Now let's go to cases. The first case was a female infant who started having blood and mucus in stools from 4 months of age. This child was admitted elsewhere and was started on antibiotics, steroids, and soy feeds, but didn't respond. And then she was put on extensively hydrolyzed formula and an amino acid formula, keeping in mind the diagnosis of cow's milk protein allergy. At 9 months of age, this child passes stools through the vaginal orifice was noticed, and this is the time when she was brought to us. There was no history of sibling death, no consanguinity, no family history of IBD or immunodeficiency. When the child came to us, abdominal examination did not reveal anything. On perianal inspection, there was a rash, and as you can see here, that there was a fistulous opening and there was a rectovaginal fistula also. This child had raised platelet count, raised CRP and ESR, and we went on to evaluate this patient. And he showed that on colonoscopy, this child had deep ulcers in the colon. There was pancolitis. The histopathology was just showing inflammation and crypt distortion. It was negative for CMV and tuberculosis. Upper GI was normal and a small bowel was normal. We worked further for immunodeficiency, the immunoglobulin profile, DHR test for chronic granulomatous and lymphocyte subset analysis. All was normal. This child was treated with biologicals also and did not respond. So what we had was a child who had infantile onset of colitis with failure to thrive, perianal disease, fistulizing disease, rectovaginal fistula, no response to immunosuppression, including infliximab. And this child, we had to resort to a terminal ileostomy as a diversion procedure because this child was not responding to any treatment and was going down the hill. So we got the genetic sequencing done, and it showed that this child had a homozygous mutation in the IL-10 receptor and was advised for hematopoietic stem cell transplantation. As we all know that IL-10 is an anti-inflammatory cytokine, and when this pathway is functioning normally, it inhibits the lipopolysaccharide-mediated release of TNF-alpha through the JAK1 and tyrosine kinase 2 receptor pathway, and therefore it keeps the inflammation under check. Once we have a defect in the IL-10, there is uncontrolled inflammation, and the child presents to you with VO-IBD. And the most often criteria or the most often symptoms with which these children present are, they often have a present in the first few months of life. They have severe perianal disease, enterocutaneous or rectovaginal fistulae, chronic folliculitis, arthritis, recurrent respiratory diseases, and failure to thrive. They have a poor response to conventional immunosuppression, as was seen in our case, and they respond very well to hematopoietic stem cell transplantation. And as you can see, that these are 5 studies, and anywhere from 8 to almost about 30% of these children, depending upon the selection criteria, had these IL-10 mutations. Now, going on to the second patient, this was a 3-year-old male when he came to us. This child again was having colitis from first month of age. He was having fever on and off and had BP eczematous skin rash for about a year. And there was failure to thrive. There was no consanguinity, no suggestive family history of IBD. This child had mild pallor, had an eczematous skin rash, and there was excoriation of the skin and the ear. He had a 2 centimeter soft palpable liver. The spleen was not palpable. We went on to evaluate this child. He had anemia, he had thrombocytopenia, and we found that his ESR was raised and CRP was mildly raised. When we went ahead and did the colonoscopy, we found that from the rectum to the cecum, there were discrete aphthous ulcers and the terminal ileum was normal. Upper GI study and CT enterography was also normal. Histopathology just showed inflammation with plasma cells and neutrophils. The immunoglobulin profile, IgG, A and M were normal, whereas IgG-E was raised in this child. So what we had was a 3-year-old child who had colitis, sepsis, eczematous skin rash, thrombocytopenia, hepatomegaly, and failure to thrive. And because of this combination of thrombocytopenia, eczema, and colitis, we thought of Wiskott-Aldrich syndrome. He was treated with emollients, topical steroids, and during his stay, the skin lesion improved, but colitis persisted. When we investigated, we found that there was a homozygous single base pair deletion in the Wiskott-Aldrich syndrome gene. He was advised bone marrow transplant, which he underwent, and the child is doing well. So Wiskott-Aldrich syndrome is a unique condition which is X-linked, and therefore it presents in boys, and it is characterized by a typical triad of thrombocytopenia along with small size platelets, eczema, and recurrent infections, which could be pneumonias or ear infection, and the colitis-like presentation along with eczema often simulates, and these patients are often misdiagnosed as milk allergy. They have a bleeding tendency, which may present as hematemesis, purpura, hematuria. They have lymphadenopathy, hepatosplenomegaly, and presence of eosinophilia, IgG, and the boy because of the X-linked nature towards Wiskott-Aldrich syndrome. And these patients, they respond very well to a bone marrow transplantation. So after having seen these 2 cases, the question comes as, when do we suspect a monogenic disorder when we have a child who has symptoms of IBD in less than 6 years of age? If it's an early onset of disease, especially less than 2 years, if there is history of parental consanguinity, or there is a positive family history, or you find that there are multiple boys who are affected in the family, if there is early perianal and fistulizing disease, if you find that the patient is not responding to the conventional immunosuppressive and biologicals, if the child is having extraintestinal manifestations in the form of arthritis, skin lesions, albinism, or woolly hair, if there is associated autoimmunity like diabetes and thyroiditis, where we suspect an IPEX syndrome, if there are recurrent infections, especially with atypical organism, which point towards the presence of an immune deficiency, if there are lymphoid abnormalities like a splenomegaly or a lymph nodes enlargement and abscesses, Or if you find on histology that there's apoptosis, which points again towards IPEX syndrome, and autoimmune enteropathy, if there's lack of plasma cells, which suggest presence of CVID, if there are pigment-laden macrophages, which are seen in chronic granulomatous disease, if these pointers are present and the child has a disease onset early on, then we should suspect monogenic disorders. Now, looking at how was the very early onset IBD in our experience different from the older IBD? And this is basically the two studies, one the multicentric study and the second the data from AIG. As you can see that IBD-U was more common in the very early onset IBD, 30% versus 1.6%. Even the patients who were diagnosed with Crohn's disease more often had an isolated colonic disease, and this makes differentiation between UC and Crohn's a little different in this age group. The disease was more severe. They had a lower weight. They more often had a bleeding per rectum, and pain abdomen was less frequently seen in the very early onset IBD in an Indian subset of patients. Whereas perianal disease, extraintestinal manifestations, and positive family history were equally common in both the very early onset and the later onset disease. Therefore, whenever we have a child with very early onset IBD, apart from the routine evaluation, a basic immunological workup with immunoglobulin profile, complete hemogram platelet size, and an advanced immunology looking for CHD, chronic granulomatous disease, for oxidative burst, lymphocyte subset, and special staining for these immunodeficiency disorders, and then at the end a genetic sequencing so that we can pick up the exact disease which is causing this manifestation is absolutely mandatory. And here the help of an immunologist is very useful. When we looked at our data of treatment, how our children were treated in the multicentric study, you can see that steroids and aminosalicylates were most often used. Azathioprine and methotrexate were used more often, roughly to the tune of 40 to 50% of the patients, but biologics were used very infrequently to the tune of about 5% at diagnosis. So what our data showed to us that for Crohn's disease patient, we hardly used nutrition as a treatment paradigm, and nearly 10 to 18% of our children had received anti-tubercular therapy prior to being diagnosed as Crohn's disease and receiving the treatment for Crohn's disease, whereas biologics and surgery along with enteronutrition were underutilized. This highlights the importance of using early biologic therapy, because whenever we use early biologics, this is the only group of medicines which have been shown that they can prevent the growth failure, and it has also been shown that early use of biologics may decrease the penetrating complications in Crohn's disease patients. Therefore, as per the recommendation of 2020, amongst the Crohn's disease patients, if they are presenting to you with growth delay, if they are presenting with extensive disease, that is panenteric disease, deep colonic ulcers, or perianal disease, this is defined as a high-risk group, and these patients should be considered for an upfront biologics. Now, nutritional therapy is coming as a very relevant therapy because children are often having growth failure, and repeated courses of steroids for treatment of inflammatory bowel disease often complicates this issue. Therefore, initially for many years across European countries, exclusive enteral nutrition was being used as a modality to induce remission in patients with mild to moderate Crohn's disease. And this was seen in it was successful in about 70 to 80% of patients, which was equally good as steroids, but it led to mucosal healing in 74% of patients in contrast to 33% with steroids. But the problem was that in this therapy, the child is asked to have only that nutrition, only that formula, and he's not allowed to eat anything else. So you pick up a formula which is a polymeric formula, and the child has to drink that, or an NG is placed and the child is given that formula and only that formula for the 6 to 8 weeks that he's getting the exclusive enteral nutrition. And therefore, there was a problem of compliance and acceptability. So recently, in the 2020 and the 2019, we have seen that Crohn's disease exclusion diet has come up, which is basically a recognition that in our diet, there are certain items or certain food items which are pro-inflammatory and have an inflammatory phenotype, whereas there are certain other food items which are anti-inflammatory. And I can't go into the detail, but there's a lots of work being done in this in the last couple of years. And a recent study has shown that if you gave the patients a Crohn's disease exclusion diet plus 50% of the calories from the formula, in comparison to a child who's getting only exclusive enteral nutrition, that is only the formula. So in the exclusion diet, the child is allowed to eat solid food, whereas a list is given which is allowed to eat items from that food. And so that food plus 50% from formula, vis-a-vis only the formula, it was found that the Crohn's disease exclusion diet plus the partial enteral nutrition was better tolerated than the exclusive enteral nutrition in children with mild to moderate Crohn's disease, and it induced remission in a higher proportion of patients to the tune of 80 to 85% rather than exclusive enteral nutrition. Therefore, it's very relevant that we start thinking about it and start using either Crohn's disease exclusion diet or exclusive enteral nutrition in combination, either as a monotherapy or for drug de-escalation therapy. And it has also been found to be useful in patients who are becoming refractory to biologics as a salvage treatment. And this has been shown to be successful in about 60% of the patients. So to conclude, I would like to say that pediatric inflammatory bowel disease is increasingly being recognized in India, especially in the last decade. Crohn's disease is more common in the south, whereas ulcerative colitis is more common in the north. Overall, the disease location and phenotype of PIBD in Indian children is similar to the West, but familial IBD is less common in India as compared to the Western population. Nearly about 15 to 20% of our patients are diagnosed at less than 6 years of age, which is the VO-IBD group, and these children have higher prevalence of IBDU, more colonic involvement, more severe disease, and that is why a stepwise evaluation of the disease extent, the upper small bowel and the colon, and also a stepwise evaluation of this very early onset IBD group, including genetics, is essential for a correct diagnosis so that you can identify those who have a monogenic disorder. The therapeutic options of enteral nutrition, biologic, and surgeries are underutilized in our country, and we need to make an effort for an early diagnosis of PIBD and early use of biologics in the high-risk group of Crohn's disease. We need to look at enteral nutrition and start using it either as a sole therapy or as in combo therapy in the correct situation. And while we are treating children with IBD, a serial monitoring for response and growth is essential. And apart from clinical evaluation, if we include CRP or inflammatory markers and fecal calprotectin along with the clinical evaluation, it gives a better assessment of the mucosal healing, because in children we cannot keep on doing repeated endoscopic procedures very frequently. A holistic management of the children with PIBD is essential, with attention to nutrition, growth, vaccination, social well-being, and a proper transition to the adult services when they reach around 18 to 20 years of age. And there is a very strong need of multicentric prospective studies for better definition of PIBD in our country. Thank you very much for the patient listening. Thank you.
Good afternoon, everybody. At the outset, I must thank Dr. Manoj Sahu and Dr. Avinash for giving me this opportunity to speak at the midterm Endocon. It's a different format. It's all virtual, but at least we get to meet and connect and learn science. The topic for today is endoscopy in inflammatory bowel disease. Now, as you can see, there is a big armamentarium of technologies available for endoscopy or endoscopic evaluation of inflammatory bowel disease. It starts from the simple upper GI endoscopy to colonoscopy, enteroscopy, capsule endoscopy, the newer imaging technologies today, and finally artificial intelligence, computer-aided technology to really help us understand or assess the disease better. There is this established role, therefore, of endoscopy in IBD. Number one, initial diagnosis for the extent and severity of lesion, monitoring therapy, whether there is mucosal healing or not, therapeutic interventions. Today, not only just mere stricture dilatation, but we are expanding beyond. And of course, early detection of dysplasia and cancer surveillance. So endoscopy actually was a game changer in IBD management. And if you see this, the role of endoscopic examination of the bowel has evolved continuously since the first description of the utility of sigmoidoscopy for the diagnostic workup and subsequent follow-up of patients in the famous True Love and Wits trial. That changed. That's how steroids came in, and we came to know that steroids could heal. So colonoscopy is essential for diagnosis. It has given us an insight into the colon, and as simple as with one procedure from normal colon, we can say whether it is ulcerative colitis or Crohn's disease. It enables us differential diagnosis. Not only do we see, we can get tissue for the pathologist to see. The biopsy, which actually aids in the differential diagnosis of IBD. We can assess the extent of disease. This is ulcerative colitis. You go in and you can say whether it's pancolitis, so left-sided colitis, or proctosigmoiditis. You see this image. There is left-sided ulcerative colitis, and you can see a standard normal demarcation line. Based on this, you can decide what form of management will be helpful for this patient, whether it will be only enemas or suppositories or combination, depends on what you see. We can grade for severity of disease. It could be just mild disease, as you see on your left side, moderately severe, or severe disease. Accordingly, numerous indices have now been developed. I'll not get into the details of this. There are many such. The Mayo score is the one which is most used, such that between endoscopists, we can understand. And when we recheck the colon, we can compare. So 0 is normal or inactive disease, mild disease, moderate disease, and severe disease if there is spontaneous bleeding or ulceration when you see inside. There is the UCEIS score, and as I said, there are many scores which have been used, but Mayo is perhaps the one which is most common. Similarly, for Crohn's disease, you can assess the extent of disease, the areas of involvement, assess the severity. Here again, the simple endoscopic score in Crohn's disease, you assess the ulcer, the ulcerated surface, affected surface, and the amount of affected surface, the narrowing, whether it is none or no narrowing, or single passable stricture, multiple passable strictures, or impassable. Accordingly, you can assess the severity. And ultimately, if you can assess the severity, you can manage accordingly. Management is always based on extent and severity of the disease. An important area after that is monitoring of treatment. Once we see such severe disease as you see, we initiate treatment. We need to know, is or the ulcers healing? Is the patient really feeling better? When he says he is feeling better, are there still ulcers left behind? And as you can see, this is what every endoscopist would look for, that you recheck the colon post-treatment and assess for complete healing or mucosal healing. That again can help you to decide what level of treatment will be needed in the future. Monitoring post-operative recurrence. We do a surgery for a Crohn's disease. We start treatment to prevent post-operative recurrence. But we cannot wait for another stricture to develop, another surgery. So we need to check. And there again, it is endoscopy in IBD. the Rutgers famous score of I0, I1 with less than 5 aphthous lesions, I2 with more, diffuse aphthous ileitis, and of course, large ulcers, I4. Evolution of treatment goals therefore has happened with the advent of such easy technology to assess the colon. Today, we don't wait for only improved symptoms or mere clinical remission. We are looking for mucosal healing, deep remission, and we feel, and the current trends are, that perhaps that will change the course of disease. And how do we do it? The factors: timing, target, treat to target, reach that deep remission. And how do we track it? Realization of remission, sustenance of remission is only by endoscopic evaluation. A treat to target approach leads to superior outcomes. This was a famous study recently completed, the CALM study, in which it was clearly shown that at 48 weeks since randomization, patients who were treated to target and mucosal healing was achieved were the ones who fared much better with no deep ulcerations and CDAIS less than 4. I'll spend a little bit of time on the small bowel because this is where the endoscopy has evolved to. After colonoscopy and upper GI endoscopy, the small bowel was like that deep tunnel. We did not know what was going on, but that changed with the available of various deep enteroscopy technologies and as well as the capsule endoscopy. And if you see here, how easy you can see why there is bleed, whether there is an ulcer there or not, and take decisions of management accordingly. Therapy for any form of small bowel disease can actually avoid a major surgery. And we'll come to the therapy part of it later. Spiral enteroscopy, a new technology in the field. If you can see, you can actually go from the mouth down to the colon by a single sitting and assess the entire small bowel. And you can see Dr. Mohan here, how he is doing the spiral enteroscopy and giving us a view of the entire small bowel. Comparison between the three enteroscopic techniques: there is single balloon, there is double balloon, there is spirus. Primarily, they are all similar, but perhaps the spirus has the greatest length that can be achieved. Of course, it is done under higher sedation or general anesthesia, but still for cases in which you are avoiding surgery, there is a bleed and you need to tackle it, it can really work wonders. So the role of enteroscopy in Crohn's disease, it has allowed diagnosis, enabled biopsy, and therapeutic interventions like hemostasis or stricture dilatation. Then, of course, the capsule endoscopy. Many patients prefer this if there is no stricture. Of course, unexplained disease, we do the capsule endoscopy. We have to be careful. If there is a stricture, we cannot do it. The incremental diagnostic yield increased. We identified small ulcers, and then there were many mild cases of Crohn's disease which improved, but at the same time, non-specific findings also increased, and hence there were, which is significant. So there was the Lewis score which came. Then there was the capsule endoscopy Crohn's disease activity index based on the findings of villus edema, ulcer, stenosis, stricture, extent of disease. Both are comparable in performance and any one can actually be used. We then come to the new and evolving area, therapeutic endoscopic procedures in IBD. The most common and the first is stricture formation is common, and endoscopic balloon dilation has been done. The emerging techniques are endoscopic electroincision and then stenting for selected cases. For this, the pre-procedural preparation is important. We need to have a CTE or MRE. before intervention, optimal bowel preparation, monitored anesthesia care or GA for patients undergoing deep enteroscopy, fluoroscopic guidance with complex strictures or multiple long strictures. Carbon dioxide insufflation is needed. Concomitant medications is again important. Systemic corticosteroid could be associated with an increased risk of complications. Biologics, however, can be continued, but antithrombotic agents should be discontinued. With this pre-procedural preparation, endoscopic balloon dilatation is efficacious. It's efficacious for primary or anastomotic strictures, for small number in close proximity, those strictures. If the strictures in general are not endoscopically transversible, balloon dilatation can be done. Small caliber endoscopes with higher flexibility is often preferred because that gives a good grip. Graded balloon dilatation is done to a maximum of 18 to 20 millimeter. Wire-guided balloons recommended for high-grade angulated or non-transversible strictures. What we should do as a routine is a biopsy of the stricture should always be taken at the index balloon dilatation. Concurrent intralesional steroid injection is now generally not recommended. Also, balloon dilatation should be avoided for strictures with deep ulcerations, strictures with pre-stenotic luminal dilatation, or concurrent fistula or abscesses adjacent to the intestinal strictures. Endoscopic electroincision. This particularly works for, if you know, anorectal strictures. You can see in the picture here, I think Boshen and his group has actually done a lot of work in this area, and can be made using various knives. You know, electroincisions are made using the endocut mode, and you can see how nicely it opens up. In select cases, fully covered removable metal stents have been attempted, but as I said, this is the evolving area. The other evolving areas are endoscopic management of fistulas and abscesses. So depending on the fistula location, number, length, complexity, associated bowel inflammation, we can decide whether an endoscopic treatment is possible or not. So the main principles would be to open the fistula tract, to close the feeding side or primary opening of the fistula, example with an endoscopic clipping, keeping the exit orifice, that is the secondary opening, or to fill up the tract with certain agents like fibrin glue or plug. Varied results regarding the fibrin glue, but still these are, as I said, upcoming things which are being done. So endoscopic fistulotomy, if you see that, this is a picture of a patient with a post-op pouch region fistula, and it is just being anastomosis.
Ma'am, sorry to interrupt. Hello?
Yeah.
Ma'am, sorry to interrupt, but then you just got stuck for a couple of moments. I think for 2 minutes, you'll probably have to redo this slide. We will edit it.
Okay, which slide? This slide?
This slide, ma'am. Ekta, this slide, right?
Yes, yes, this one only.
Yeah.
Can you see me now?
Yeah, ma'am. Pretty audible. It was just, it was getting stuck and we couldn't hear you properly. It was lagging a lot.
Okay.
Yeah.
Similarly, nowadays, endoscopic drainage has been attempted via the for fistulas and ceton placement, wire-guided ceton placement. You know, you use a biopsy forceps to grab the tip of the jag wire introduced from the external opening to the internal opening of fistula tract and tighten it with a ceton. Similarly, endoscopic clipping of pouch vaginal fistula. These are rare, complications, but once it happens, Other than surgery, we had limited options, and this is the, again, work is being done, and hopefully endoscopically we will be able to avoid major surgeries. We come to colonoscopic surveillance and monitoring. We know that risk of colorectal cancer in IBD is elevated, highest in ulcerative colitis, followed by Crohn's disease, and you can see the difference from the general population. The cumulative risk of this increases over time, and by 30 years, at least 18% or 18 to 1/5 of patients may develop a colorectal cancer. So there has to be surveillance. We need to check. So there are no control trials. Most of the guidelines are based on clinical experience, but primarily they agree that after 7 or 8 years, for all UC, we need surveillance. At diagnosis, if there is primary sclerosing cholangitis, because that increases the risk. So random biopsy protocol was suggested by AGA and ACG, surveillance based on risk stratification by the BSG. Ultimately, all agree, whatever it is, if the disease is more than 7 to 8 years, the patient is much better off with a surveillance colonoscopy, particularly relevant for our country because colonoscopy is not that expensive, and it may be worthwhile having a check and then ensuring, because newer techniques are available. The patient need not go for colectomy all the time that there is a dysplasia. Technologies like endoscopic mucosal resection, endoscopic ESD are the new options which can be used particularly for unifocal dysplasia. So you can see the scenic international consensus statement. Dysplasia should be characterized as resectable, endoscopically resectable, or non-endoscopically resectable. After complete endoscopic removal, surveillance recommended rather than colectomy. After complete endoscopic removal of non-polypoid dysplasia, again, surveillance is suggested rather than colectomy. So you can just maintain the surveillance colonoscopy rather than going for a major surgery. So initial screening colonoscopy after 8 years, no dysplasia, surveillance in 1 to 2 years, indefinite repeat surveillance at 3 to 6 months, flat dysplasia, you can either unifocal, you can repeat surveillance at 3 to 6 months, multifocal, low-grade dysplasia or high-grade dysplasia, patient should go for colectomy. DAM is now not used much, but if it is non-adenoma-like or adenoma-like lesions, polypectomy can be done and repeat surveillance in 6 months, but non-adenoma-like goes for colectomy. Endoscopy in IBD, there are of course opportunities for improvement. What the old facts were that the patients were at risk of chronic inflammation, surveillance colonoscopy, detect dysplasia, go for colectomy. If there is cancer, secondary prevention, and then finally. But now there are recent advancement of relapse by doing advanced imaging, that will this patient relapse? Avoid unnecessary biopsies, not the random biopsy anymore, targeted biopsy. Early detection, easy surveillance, EMR, ESD if needed. Real time, if possible, the pathology also while you're doing it. So step forward was chromoendoscopy, using of dyes. You can actually characterize the lesion and detect the lesion much better. Indigo carmine, methylene blue are the ones that have been used. So initially a pan chromoendoscopy with a dilute solution, followed by targeted chromoendoscopy if you identify a lesion for lesion characterization. So the practical matter, if you're doing dye spray, it's messy, labor intensive. There is the question of unequal distribution of dye, as you can see over here, issues of preparation and inflammation. So easy detection of flat lesions. If you see here, it is possible, but chromoendoscopy yields more dysplasia than conventional. But to avoid that messiness, digital chromoendoscopy or narrowband imaging available at the switch of a button is what would be preferred. And if you see here on white light endoscopy, you can barely see anything. And then on narrowband, you can clearly identify the lesion as you're seeing here. And that helps us in inflammatory bowel disease diagnosis. This was a case long time ago, but that's how I got interested in advanced imaging. This was a patient doing the rounds, no treatment, nothing was working. And then on narrowband, we identified the fine linear ulcer and diagnosed it as a case of Crohn's disease. Again, the scenic recommendations: high definition better than standard definition, narrowband imaging not a replacement for chromoendoscopy yet, but many Japanese studies now say that this is much easier and more applicable for our practice, where there is always time is a factor. Then we come to confocal endomicroscopy. As I said, can we see much better while we are doing colonoscopy? And that is confocal. So if this is the normal colonic mucosa seen by the pathologist, if we are using confocal endomicroscopy during colonoscopy, we will see something like this. So this is almost what the pathologist sees and can help us take decisions then and there, where to take biopsy from, whether to remove it or not. It correlates well with histology. If you see here, normal crypts and then tortuous crypts seen in a hyperplastic polyp. Advances now, computer-aided diagnosis. This is a recent paper this year which says that application of an innovative illumination with a single wavelength monochromatic light source. Okay, this endoscopic system is the first that optically visualizes the pericryptal vessels and gives us a computer-aided diagnosis for scoring histologic remission in ulcerative colitis. These are developments which are going to change the field. Artificial intelligence in IBD endoscopy. It is reaching the headlines of journals. The EndoBrain from Olympus is already available. It actually, while you are doing the colonoscopy, will tell you, as you can see here, neoplastic, high confidence, probability of 99%. So a lot of our headaches and tasks are gone. It is a constant help with us, if not everything also. If the EndoBrain suggests that this area is possibly neoplastic, we can take biopsies then and there, and in fact go in for therapy immediately. After all this endoscopy discussion, nothing can end to nowadays without the COVID-19 story. After COVID-19, endoscopy in inflammatory bowel disease, what should we do? Suspected new diagnosis of IBD. First, rule out COVID-19. No diagnosis, first do a Clostridium difficile. If it is negative, rule out IBS, meaning thereby colonoscopy comes later. Do fecal calprotectin. Try and see if you can avoid a colonoscopy during the pandemic. If there is a severe acute flare of ulcerative colitis, again, rule out COVID-19. After ruling out COVID-19, then do a stool test to rule out any other gastrointestinal infection. Test for C. diff, test for CMV. If it is a confirmed diagnosis of flare-up, also assess had the patient had a colonoscopy in the previous 3 months. Only if there is no colonoscopy in the previous 3 months, possibly you should go for a sigmoidoscopy. Otherwise, admit the patient and start treatment with steroids, with higher level medications. And if doesn't respond, only then go for a colonoscopy. Similarly, Similarly, for obstructive features, go for abdominal CT, MRI, assess for COVID-19, and then take diagnosis. Overall, whatever be it, new diagnosis of IBD, severe acute flare-up of ulcerative colitis, or partial colonic obstruction in patients with IBD, rule out COVID-19. Colonoscopy should not be routine. Colonoscopy only in need, and if needed, carefully with full protection in a dedicated endoscopy room, negative pressure room preferred. If not available, wait 1 hour with open windows before and after the endoscopy. Wear your PPEs, take your self-protection as well. In addition, never allow relatives and caregivers and patients should also wear facial mask and possibly gloves. So the key messages today are endoscopy plays a fundamental role in the diagnosis, management, and treatment of IBD, we know. Small bowel evaluation nowadays has become easier with the deep enteroscopy technologies available. And that has changed our management of IBD as well. There is an increased risk of colorectal cancer in long-standing IBD. Surveillance colonoscopy aims to detect dysplasia, early cancer, and reduce morbidity and mortality by simple colonoscopic procedures like EMR or EST. Therapeutic endoscopy is now expanding beyond stricter dilatation to fistulectomy, abscess drainage, use of stents, and as I mentioned, EMR and EST. Advanced endoscopic techniques, including computer-aided AI systems, have the potential to improve dysplasia detection, target biopsies, and ultimately all this will help to improve outcomes for a chronic lifelong condition like IBD. We are yet to see the future. The robot may tell us now. I thank you for your attention.
We will start the panel discussion. The first question has come to Dr. Anshu Srivastava. What should be the basic screening tests that we have to do to rule out immunodeficiency in a child with chronic diarrhea?
See, there is no one standard test which we can say that if you have done this, all immunodeficiency disorders have ruled out. The first and most important thing is the history. Any child who has got immunodeficiency, we are not talking here only of the IBD. They'll have recurrent infections, they'll have infections at different sites, they'll be requiring more courses of antibiotics and all those things. So that is a suggestion that this child is prone. Second is, if you're talking of the VO-IBD group, then as I mentioned that if there is an onset which is definitely below 1 year, or I would say 2 years, and especially if you say that the younger the onset, if you have a child who's having an onset at 2 months, they're more likely. So it's that age group. Plus, if you find all those signs that they are atypical infections, there's hepatosplenomegaly, there is arthritis and all those things, and there is no response to the standard treatment, that's a subgroup with a high suspicion. And we will start, like if you say I have a 8-year-old child or a 6-year-old child and who's presenting just normally, I would perhaps do a retrovirus, I would just do a immunoglobulin profile, and I would look at the T cells, and that's it, number. I don't need to go beyond it. But if I'm getting clues, or if I have this high risk group, then I will definitely do the immunoglobulin profile, IgG, A, M, and E. We would ask for the DHR test, which we do for the chronic granulomatous disease. If we find clues, like if I find IgE levels are raised and there are thrombocytopenia, as I showed you, I would go for the viscotalric gene. So it depends upon the clinical manifestation and how strongly we are suspecting. And this is where we utilize our immunology colleagues always, because they come in and we together decide, okay, this child first strata, level 2, level 3, level 4. Now you are treating and simultaneously you are finding that the patient is not responding and is developing new fistulae. You have started all immunosuppression, you are giving biologics, he's still not responding, and he had an onset at 2 or 3 years of age. Then my alert bells will start ringing. No, this is may not be. So I may even start for an NGS and ask the child's family to spend 20,000 rupees and get an NGS panel for these monogenic disorders straight away. Because many a times asking for independent tests may not be even maybe more time consuming and turn out to be more expensive in the long run. So, but if it has to be case based, I can't prescribe that, okay, do this and it is done. But definitely ask for an immunoglobulin profile in all patients. Definitely rule out retrovirus infection in all patients, because we have seen even younger patients 2 years old who are presenting with diarrhea and they have this kind of a thing, and then go case wise.
Okay. The other question is, some of our younger adults who are suffering with IBD have a question as to what is the risk of my child developing IBD if one parent or if both parents have inflammatory bowel disease.
Definitely the risk is higher. If you have a family history of IBD, definitely the risk is higher. And for that, actually right now they are doing the studies where they are trying to manipulate the gut flora. The meconium study and all those things are on, where they are trying to manipulate the gut flora of the pregnant woman so as to see whether the risk of transmission to the child of the mother who has IBD is going down or not. But there is no prophylactic therapy which has to be offered at this point of time. So we have to counsel them that there may be an increased risk, but I don't think they have to worry that much about it when they are asymptomatic.
No,
Dr. Rupa, you wanted to add to that?
Like to, yeah, I just thought I'd just add a few words. We actually, for our patient population, we've just published in about the family history of IBD, and I think with a large number of patients of more population, the family history is much lower than what is being reported from the studies. So I think it is important, because when you are talking to the young adults, ours is ranging between 4 and 5%, whereas for Western studies, and I think agree with me, there are many pediatric IBD separately to, and most of the pediatric IBD patients, not most, a larger number will be having a family history compared to the adult onset IBD. So it depends on the onset of IBD. So younger onset IBD or pediatric IBD, the incidence of family history is higher. But when you are counseling a patient, the possibility of their child developing IBD, you should not tell them that you should not plan, because the risk is much lower compared to other studies reported.
Okay. The other question raised is, how do we improve compliance to enteral nutrition in children? Is there a role of prophylactic placement of a PEG or long-term nasogastric or nasoenteric feeds?
When we are giving exclusive enteral nutrition, and that's the reason it has not taken up in our country in that big sense, because it needs a total dedication for 8 weeks. So if you have a child, what I experienced when I was outside was that they used to place an NG, but never a PEG, because this is not a permanent thing that you are asking for. So it's an 8 weeks, and by the end of 3 to 4 weeks, you will get an assessment whether the patient is responding or not responding. So in that case, if you have an older child and the child is dedicated, there's no need for an NG. But if you have a child where you have plus minus, then you may need to put an NG and feed that. But PEG, definitely we don't ask for.
Dr. Basumani, this is a question to you. What are some of the mimics of IBD on colonoscopy that you have seen in your practice and that endoscopists have to be wary about before the diagnostic inflammatory bowel disease?
Thank you, Amit. Thanks to Rupa and Anshu for excellent presentations. Real treat. So, right from tuberculosis in various places, from ileum to ascending colon, chronic NSAID use. People who have abused NSAID for many years for headaches and other pains. even people on isoretinoin for acne treatment, isoretinoin mimicking Crohn's disease like after ulcers. In the olden days, gold and other disease-modifying agents can cause. Even glutaraldehyde, the one we use to clean the scopes. I've had patients who had normal colonoscopy day 1. Day 5 had a florid fulminant colitis due to glutaraldehyde. I've seen people with, of course, Clostridium difficile and antibiotic-associated colitis. Ischemic colitis is a very classic mimicker of segmental colitis, but the watershed zone and classic distribution and preceding severe pain due to migraine or mesenteric vascular event. I've seen post-radiation colitis mimicking IBD. All these I'm recalling from my own personal series. So these are some of the things. Of course, tuberculosis comes first in the differential diagnosis. CMC Vellore has published a lot of papers distinguishing radiological, endoscopic, and microscopic features. But at the end of the day, you have maybe this or maybe that this clinical conundrum where you carefully exhibit ATT trial and take a stock-taking colonoscopy and clinical assessment in 3 to 6 months' time. If the lesion disappear and patient doing well, carry on. Otherwise, revisit the possibility of Crohn's disease. Very rarely I've been misled by even lymphoma and adenocarcinoma of the ileum mimicking IBD. We have taken for granted without histological proof. The biopsy was not deep enough to give the diagnosis, but during the clinical progress. So IBD is not a pathognomonic, a sine qua non disease. You take everything into picture, clinical, radiological, endoscopic, as well as biopsy. When histology is not, and the index ileocolonoscopy is not dogmatic, is not diagnostic, please keep an open mind and don't be let down in the garden path.
Okay. Sridhar, you are in an academic center at KM Hospital. What is the grading that you use for grading ulcerative colitis in your unit? And do you use the Mayo score or UCIS? And why do you prefer one over the other?
Thank you, Amit. Thank you. So we at KM started using UCIS around 3 years back. We were using Mayo before that. Only thing, the amount of overlap that you see in the Mayo grading is a little, it's not as objective as the UCIS is. So we started using the UCIS. Now, clearly the Mayo has the advantage of having some clinical scoring as well. But these are the history and is something that you obviously take for the patient. So the UCIS is more objective when you're coming to grading the severity of the disease, which is why we started around 3 years back, changed over to the UCIS.
Okay.
And UCIS is the most validated
Absolutely.
one.
Absolutely.
It is the
Absolutely.
only validated questionnaire. So it is a little difficult, but if you're planning to write papers, I think Dr. Sridhar would be thinking the same, that if you are planning to write, it is better to have a UCIS score.
Yeah. Yes, ma'am.
When it comes to small bowel Crohn's, Dr. Rupa, this question is for you. Are you happy to make the diagnosis based on imaging, or do you want a small bowel enteroscopy in all these patients?
I would prefer to have an enteroscopy, but enteroscopy is not available at all centers, and we have to keep that in mind. But in our center, we would definitely prefer to have an enteroscopy because it gives us the first time what is the status. But later on, we do not follow up with repeat enteroscopies. Okay. So the first impression, the first biopsy, the first look, we do it. The other is we have therapeutic procedures available now. So multiple strictures in the small bowel, you would rather go for enteroscopic dilatation and at least see how tight the strictures, whether it can be dilated or not, and save surgery. Because in Crohn's disease, you should not go for a surgery, I think, at the drop of a hat, particularly for extensive small bowel disease. So that is the reason why I'd prefer to go for an enteroscopy and then evaluate and treat accordingly.
the other scenario that we face is that of post-operative Crohn's. Dr. Shinoy, in your practice, when do you scope the patient after surgery for Crohn's disease?
Hardly I have subjected only 1 or 2 patients with for a surgery where initially we had a diagnostic problem, dilemma. The patient had come with the intestinal obstruction. Usually suggest after 6 to 12 months, where you expect around 1/3 to 1/4 of them having a recurrence as such. Subsequently 10%, because Crohn's is a chronic and relapsing disease. You need to educate the patient that it's not the end of the treatment, that surgery is not the end of the treatment. You need to continue the follow-up as such, that needs a proper surveillance.
Dr. Anshu, now we are moving the targets to mucosal healing and histological healing. In children, sometimes it is difficult to do colonoscopies frequently. So how do you follow up your patients? How do you see that targets are met?
We do always, for documenting as a gold standard mucosal healing, definitely we need to resort to colonoscopy. So it's not that we will do a colonoscopy and make a diagnosis, then follow them clinically, follow their CRP, follow their fecal calprotectin. Once we are reasonably sure that, okay, he's been in remission for a significant amount of time, and so now it's like about 1 year down the diagnosis, the child has been very stable, doing very good, then we will repeat a colonoscopy. But not at every 3 months. And obviously that would depend upon the age of the child. If a child is 12, 13 years, we are more easier to do it. But if a child is 2 years old, then we would want a longer period of confidence that yes, the child has been doing well before we subject him to that. But we do use colonoscopy to document mucosal healing because we have to take biopsies also at that point of time.
Yeah, Dr. Shinoy, you want to make a point?
Dr. just wanted to ask you, what difficulties have you faced, whether, child coming with whether those like fistula and all, whether it is a Crohn's disease or tuberculosis, what exactly you do, whether you start them on ATT or something or follow them up?
See, that dilemma of tuberculosis and Crohn's disease is always there, but we have not seen any fistulizing disease with tuberculosis. At least in my experience, we have not seen. And we had analyzed our children with tuberculosis versus Crohn's, and we had found that presentation with rectal bleeding and left-sided colonic involvement were the two things which were taking us on multivariate towards a Crohn's disease. But otherwise, the differentiation is just like you do in adults, like we make all efforts to take tissue diagnosis. And in that scenario, if you are still stuck, we treat them with ATT response, monitor the response, repeat the colonoscopy or the small bowel imaging after 3 months, look for remission, and then go from there. There is an added component of MDR which has now started coming up, and we are experiencing adolescents, 14, 15 years old, who are having MDR tuberculosis. And that is complicating the issue because the child is not responding. Now, the step 2 question is this MDR or is this Crohn's disease? So we have had 10 to 20% of our patients who have received ATT, then gone on to even MDR and then gone to Crohn's. So it's many a times, because it's not that even if you do gene expert and everything, we get in almost like 20 to 25%, you'll get AFB seen. Otherwise, it's all clinical and investigative, not documenting the tubercular bacteria that the diagnosis is made. So we suffer the same problems just like that of the adults. But luckily, we are not seeing this intestinal tuberculosis in children who are less than 4 or 5 years of age. It's extremely uncommon. So that group is spared up till now.
Okay, so this is our last question for the day. Sridhar, I know that you are doing some work in cancer screening in IBD. Can you share with us what your protocol is for patients with IBD where you do the cancer screening?
Actually, this is something that we surveyed last year. We conducted a survey with the Indian Society of Gastroenterology for gastroenterologists and looked at image-enhanced endoscopy practices in the colon. And this was one of the questions wherein we looked at cancer surveillance in IBD. So we found that 36% used NBI, 24% used random sampling. And as Madam already mentioned, chromoendoscopy has a role, but only 11% actually use chromoendoscopy. So I mean, chromoendoscopy is still not used, but in our center, we use chromoendoscopy. I use methylene blue to do surveillance colonoscopies for patients with IBD. I think already the protocol was mentioned by Madam, but I found there was a distinct advantage of using methylene blue. We've had, at least in the last year, 3 patients who we diagnosed with an early lesion in the background of an IBD. So yeah, there is clearly an advantage of using chroma, although in practice it becomes a little more cumbersome. It's difficult, and especially requires some amount of training, because not everyone is really used to using dyes. Not everyone is akin to spending more time or doing a colonoscopy. Maybe it adds another half an hour, 45 minutes to the procedure. So that is one thing. That is one thing that I felt. So, but chroma endoscopy is the way to go.
I think we'll stop here. We've had a good session where a lot of queries have come out, a lot of questions have come out. We've had a good discussion on important topics that we don't generally come around. Pediatric IBD is a huge topic, and thank you to Dr. Anshu and Dr. Rupa for enlightening us on these topics. Thank you.
Thank you.
Thank you. Thank you.
Thank you, everybody.
Thank you, ma'am. Thank you.